Back to our channel. Today we are going to start the lung volume and capacities. So first let us start understanding the lung volume. So normally at the resting stage of lungs there is no inspiration. So for example now you are sitting in a resting position. So there is no inspiration and expiration means what it means to say is at resting stage of lungs like at complete rest there is no inspiration or neither expiration. The lungs get smaller outside the body, like now we are saying like in a person we detach the lungs, think normal lungs we detach it from the body and there is no expiration and no inspiration going on. So what happens if you put the lung outside of the body? It becomes smaller because lungs try to go inward and the chest wall always try to go outward, so the lungs get smaller outside the body. And usually the lungs in the chest cavity, so they are in expansion greater than the resting volume. So as they are put in the chest wall only, they are expanded, we know that. Because of the that's why intrapleural pressure is negative, it is maintaining the chest wall in proper place and also lung in proper place. But normally if you remove the lung and put it outside, it will become smaller when compared with your in your body size. So the chest wall gets larger outside the body, yeah. So after the expiration the respiratory system is neutral, but the lungs chest wall are not neutral. So this is important. After the expiration means you have completely thrown out the left air in your body out. So after that your respiratory system may get neutral, but the lungs chest wall are not neutral. Lungs try to collapse inward and chest wall try to spring outward. So but as they are attached to each other by pleural fluid and by in parietal pleura and visceral pleura, that is the chest wall and lungs, they stay at equilibrium, and that is the volume of resting state. So at the resting state, to find out the volume, you can understand their equilibrium point is nothing but the volume. So if the air enters the pleural cavity mainly by stab injury, like in pneumothorax, as I said already, if you stab or any other injury, there the air may enter in the pneumothorax, especially in the pleural fluid. So what happens there? Then the parietal visceral pleura are divided and the lungs collapse inward and the chest wall moves outward. So when the air enters inward, now the pleural, that negativity, the intrapleural pressure is lost. So because of this, lungs may go inward and the chest wall may go outward. So because of this, the respiratory cycles are completely disturbed. So during inspiration, the chest wall and lungs are contracted and become huge and enlarged. Pressure in the lungs decreases. Already we know Boyle's law. Whenever we are inspiring, the diaphragm goes somewhat downward. So because of this, the volume in the lungs increases, but the pressure decreases. And the air from the outside reaches the lungs, and now the volume increases by extra half liter of air. So this is very important. Extra half liter is nothing but 500 ml of air is now added. Whenever you take, so now we imagine, now for example the person who is listening to this video, you may try it on yourself. You are sitting now in the normal position. Now take some extra air inward. So now you can understand that already some air is inside the lungs. Now you are taking that extra air. That extra air is nothing but, you can take always 500 ml of extra air. That is nothing but called as tidal volume. So during expiration, no muscle contract because it recoils with greater power, as in the inspiration they are more expanded and the inspiratory muscles are relaxed. So it is a passive phenomena when air goes out. This we already know. In passive breathing, for inspiration you may need some inspiratory muscle, especially diaphragm, right? In inspiration, that too in rest or passive stage, you need diaphragm for inspiration, but for expiration you doesn't need any muscle because your lungs recoil themselves, because lungs are like a rubber band, they try to recoil themselves so they can go back to their normal position. So this is about normal passive respiration. But in forced expiration, forced inspiration, you need some muscles. For example, as we already discussed yesterday, in the forced inspiration we need mainly the muscles like uh, inspiration means external intercostals. You may need sternocleidomastoid, you need scalenus, all these are needed. For forced expiration mainly you need rectus abdominis, all the abdominal muscles like that, and also you need our internal intercostal. So all these muscles are required. So the amount of air entering air during inspiration is the tidal volume, that is that 500 ml as we discussed, that is mainly the tidal volume. We will discuss all that in detail also. So the tidal volume, the volume of air which enters and leaves the lung during the normal inspiration and expiration, that too in resting position, it's like just about half liter or 500 ml. So you can see this is the residual volume. Always remember, in lungs there is some amount of air that is always remaining, that is called as residual. Hence the name residence. You know, you stay in some residence, right? So like that the lung also have some residual volume, that always stays in the lungs, that is residence volume. And the tidal volume is the one which always changes according to your respiration, especially in rest. So now you are in rest. Now the air which is going into you is 500 milliliters, that is tidal volume, and the air again which is getting out from you, that is during expiration, that is also tidal volume. So this tidal volume is coming out and going in, that is 500 milliliters, but this residual volume is always inside your lungs. You may get the doubt why this residual volume may also not go out and come, but not, because this residual volume is always required inside the lungs, because if there is no air completely, our alveoli may get sticker with each other, and because of this the lungs may collapse and the respiratory system may fail. So this you can understand by, for example, if you take a glass slide, if you fill it with water and you can take both glass slides together, they stick, but because of water they can be easily separated. But if there is no water, if you put two glass slides directly sticked, they will stick forever. You cannot open them whatever you do. So again, if you put in water only, you can open them. So like that, there should be always some air inside the lungs to prevent the collapsing of alveoli or either the whole lung. So always residual volume should be there in the lung, and only this tidal volume should be changing, that is 500 milliliters, or you can say it as half liter. So if we do extra work to add extra volume of air to the lungs after the normal inspiration, then it is called as inspiratory reserve volume. Very easy to understand. See, inspiratory reserve volume, as the name you can see, by inspiration you are adding. So normally in rest you are having tidal volume, but sometimes in exercise or any other activities you need more, you will inspire more air sometimes, then that is called as inspiratory reserve volume, that is extra than tidal volume. Inspiratory reserve volume, after the normal inspiration, the amount of extra volume added to the lungs is called inspiratory reserve volume. And we also have expiratory reserve volume. It is an after expiration, the extra effect to remove the extra volume of lungs, that is called as, that is 1.5 liters, that is called as expiratory reserve volume. So now we have understood the inspiratory reserve volume. So sometimes what we do is we try to remove excess air, like in activities, other activities like exercises, then we try to remove more air from our lungs, that is called as expiratory reserve. Always remember, if you try to remove more air from the lungs also, you may not remove the residual volume, you may only remove the expiratory reserve volume. So we can't empty the lungs completely because chest wall can't collapse. So that's what we discussed. So because during extra expiration we bring the chest walls more inward and they may collapse. So the complete air can't come out, and it is the residual volume. So residual volume is 1.5 liters, that is like 1.5 liters. So we need to remember these values for sure. The residual volume is 1.5 liter, the expiratory reserve volume is also 1.5 liter, whereas the tidal volume is 500 ml, or you can say as half liter, and our inspiratory reserve volume is also half liter. So next let us see, yeah. So this residual volume prevents the total collapse of alveoli, because if there is no residual volume, alveoli may stick and collapse, and the surface tension may also increase. You know, surface tension increases means lot of problems. Alveoli may collapse. So we already discussed before, surfactant is used to decrease the surface tension, right? So you can see here the expiratory reserve volume. Now let us combine them and form new formulas. Expiratory reserve volume together with residual volume together from the functional residual volume or capacity. So the functional residual volume or capacity is the expiratory reserve volume with the residual volume, remember. So this both form the functional residual capacity, that is, expiratory reserve volume is 1.5, reserve volume is 1.5, so together they form the 3 liters. So they mainly prevent the collapse of lungs, they allow the gas exchange during tidal volume, and the 350 milliliter of fresh air reaches functional residual volume and reduce the oxygen tension in the lungs. So during inspiration, 3 liter plus half liter of tidal volume gives total 3.5 liter, and during expiration 3 liter minus half liter gives total 3 liters. Sorry, 3.5 minus half gives you 3 liters. So actually why we are saying this is, during inspiration already we have just now see functional residual volume is already present. So functional residual volume plus half liter is added due to tidal volume, it's 500 ml. So during inspiration, total amount of that volume is 3.5 liter. But during expiration, already this tidal volume is also present now. That is only we are going to expel now. So 3.5 liter minus half gives you 3 liter. So now let us see some of the important terms here. So first one is residual volume, second one is expiratory reserve volume, third one is tidal volume, fourth one is inspiratory volume. So these all values we have. So residual volume along with expiratory reserve volume gives us functional residual volume, which is 3 liters. So next, expiratory reserve volume with the tidal volume with inspiratory reserve volume gives us the vital capacity. So the vital capacity is the what which will be changing like during inspiration and expiration. So this expiratory reserve volume is 1.5. 1.5 plus 0.5 plus 2.53 together gives us a vital capacity. It is like about 4.5 liters. So vital capacity is equal to expiratory reserve volume plus tidal volume plus inspiratory reserve volume. So the vital capacity is to do extreme inspiration and expiration in extreme conditions. So this is very important. Normally in normal inspiration and expiration, we have the functional residual volume. For that functional residual volume only we will be keep on adding this tidal volume, or we will keep on removing it. But whenever you do in exercise or all those conditions, you need to do extra respiration. So in that extra respiration case, we use mainly this vital capacity that is like about 4.5 liters. So this 3 plus 4, that is tidal volume plus inspiratory volume together gives you inspiration capacity, that is 3 liters. So of course tidal volume with inspiratory volume gives you inspiration capacity 3 liters. And you can see 1, 2, 3, 4, that is all together. The reserve volume, expiratory reserve volume, tidal volume and inspiratory reserve volume together give the 6 liters. 6 liters is the total lung capacity. So for the total lung capacity, you can also use another formula like functional residual volume plus vital capacity, of course, right? Because functional residual volume is this both, vital capacity means this three. So functional residual volume plus vital capacity gives you the total lung capacity. So the total lung capacity is the total amount of maximum air which can be pulled in within all inspiratory effects. Like within all inspiratory effects, how much air can be pulled in. So this is the total lung capacity. So this is very easy to understand. So the all volumes and capacities can be measured by spirometer except the residual volume. So very important, except this last residual volume, all these volumes can be easily measured by the spirometer. So what is spirometer? We'll see that also, because it can't go in and out from the lungs, and the process is called spirometry. Actually, spirometry is like we use some machine and we take out our air out and in. So in every cycle of respiration we'll measure it. As you know, reserve volume cannot come out or either come in, so we can't measure it. But we also have other techniques like helium dilution method to measure it. We'll see that. So spirometer has a pipe which is connected to the mouth, and the other side with a drum full of water and inverted drum with air, and it is connected with the ink marker and attached to the paper, drawing the graph. So in a normal person, if there is no respiration, it will be straight line, and if suddenly respiration struck, the graph will be like this. It will be upward and downward. That is inspiration, expiration, inspiration, expiration. So during inspiration, the inverted drum moves downward as 0.5 milliliters of air entered, that is tidal volume has entered. So the marker moves up. So you can see in inspiration the marker is moving up, because for the functional residual volume the tidal volume is added, that is 500 ml. So the marker moves up. During expiration, the inverted drum moves upward as 0.5 liters of tidal volume air expelled. So the marker moves downward and the tidal volume graph will be. So this downward will be due to expiration. So always remember, due to inspiration there will be upward in the graph, and due to expiration there will be downward in the graph. So the graph is like this. So during maximum inspiration, then the inspiratory reserve volume and produce the total graph like this. So this is an inspiratory reserve volume, this is expiratory. So you can see the inspiratory and expiratory reserve volumes are at peaks. Inspiratory reserve volume is upward and peak, and expiratory reserve volume is downward and peak, because expiration is downward in the graph, as I already said, and inspiration is upward in the graph. So even their peaks also will be upward if case of inspiratory reserve volume, and the peak is downward if there is expiratory reserve volume. So in a spirogram, if we try to draw the graph, it would be looking like this. You can see inspiratory reserve volume and expiratory reserve volume. So this is a functional residual capacity. It also can be determined because of reserve volume is involving in it. So remember, not only reserve volume, even the functional residual capacity is not measured by means of spirometry, because in functional residual, what is the functional residual capacity meaning? Respiratory reserve volume plus expiratory reserve volume. So as residual volume is involved here, even functional, so remember, functional residual capacity plus residual volume can't be determined by spirometry. So one capacity and volume can't be determined by spirogram. Yeah, one capacity and volume. What is that one capacity? Functional residual capacity. What is that one volume? That is residual volume. So one capacity and one volume can be measured by our spirogram. So by helium dilution method, we can determine that is blood is used because we can't absorb by, yeah. So functional residual capacity and residual volume are measured by means of this helium method. So actually here the helium is put on the spirogram, and it is sent into our lungs, and 10% concentration of helium is used, 1.5 liter of air. So here what happens, after complete expiration we'll off this and we'll send the helium, so that here 10% is sent, but after the expiration only 5% will be remaining here, means the remaining 5% is here. So by this we can conclude that remaining 5% is nothing but our residual volume. So like this we can confirm the residual volume by means of helium dilution method. So 1.5 liter of air of 10% helium let equilibrate with the residual volume, then the helium concentration decreases in air to 5%. So uh, V volume plus unknown volume into final concentration gives volume into final initial. So we have a formula like this to measure this. So Vs into, that is volume of spirometry, is 1.5 liter into initial volume minus final volume by final volume, that is equal to 1.5, because here initial volume is 10, final volume is 5 divided by 5. Vs is 1.5, so we'll get 1.5 liter. So by this we can confirm that 1.5 liter is the residual volume in a lung. So effect of aging on the lungs, their elasticity is decreased. So if a person is getting more older, then the elasticity is decreased, means the residual volume is increasing. So you can understand, if the elasticity is decreasing means compliance is increasing, means this person is like emphysema person. You know, in emphysema, because of smoking, the person may have more compliance, that the inspiration is very good, but expiration is very hard because of increase in compliance and decrease in elasticity. So the same things happen in older people. So airways become narrow, but the total lung capacity remains normal and vital capacity decreases. So remember, but the total lung capacity is normal in the case of older people, but only the vital capacity is decreasing. So you know what is vital capacity? That is our expiratory reserve volume, tidal volume, and inspiratory reserve volume. You know, vital capacity is mainly used in exercises, so that will be always maintained normal. So here we have FRC, that is functional residual capacity minus expiratory reserve volume gives you the reserve volume. Yes, we know this because, you know, functional residual capacity is nothing but residual volume with plus expiratory volume, expiratory reserve volume. So if you even change that formula, you can get this. So vital capacity is more in males and less in females, and also in athletes and in broad chest people the vital capacity may be more, but in females it is less. And vital capacity after maximum inspiration or expiration, we know that when it is used. So phrenic nerves 3, 4, 5, cervical, that is C3, C4, C5, innervate the diaphragm and intercostal nerves to the intercostal muscles innervation. So intercostal muscles are mainly innervated by C3, C4, C5 cervical nerves, phrenic nerves. So the muscular myopathy, that is in muscular myopathy also the vital capacity is decreased. In myasthenia gravis also neuromuscular membrane antibody block the cholinergic receptors. So because of all these diseases, the vital capacity may be decreased, and demyelination of nerves, you know, myelin is not present, then also vital capacity decrease. And scoliosis, kyphosis, bends. So in scoliosis, actually scoliosis or kyphosis, what happens is there are bends in the spinal cord. Because of the bends, the person anatomy is different, so the lungs bends in vertebral column, so vital capacity is decreased. And lung fibrosis, infections in lungs, anterior portion infections in lungs, all this also decrease the vital capacity. And the part of the lung may be collapsed and pathological pleural fluid may be present like edema. In that case also vital capacity is decreased. You can understand if there is edema in the alveoli, then it takes lot time from the capillary to move into oxygen to move into this side, and even carbon dioxide to diffuse outward. It will be very hard because of fluid. So maybe obstructive airway disease, asthma, bronchitis, emphysema, so any kind of disease mainly lead to decrease in vital capacity. So you can see all of the diseases are mainly leading to decrease in vital capacity. So now we will also check out some important points from our textbook. So the graph which I shown in that notes is also here, you can see clearly. If you want, you can check this diagram in your textbook and learn it. And some of the important points from our textbook are like, around the trachea and around our bronchioles also there are some cartilage ring, they prevent collapsing them. So that is alveoli enlarge and bronchioles also enlarge. These are like some important points. And there are like 65,000 parallel terminal bronchioles, through each of which only a minute amount of air may pass through it. So you can see the determinants of airway resistance. Mainly bronchioles are the determinants of airway resistance. Like they like diameter of airways, tonus of the smooth muscle lining the airways, lung volume, gas density and viscosity, edema of airway lining, mucus collecting in the lumen. So all these are the determinants of airway resistance. The next, coming to sympathetic system and parasympathetic system effect on bronchioles. Actually sympathetic system leads to bronchioles dilation by mainly epinephrine or epinephrine acting on beta adrenergic receptors, whereas parasympathetic system mainly leads to bronchoconstriction. By vagus nerve it releases acetylcholine, lead to bronchoconstriction. So the treatment for this, like if the bronchioles are constricted, especially in bronchial asthma, the patient feel very difficult to mainly in expiration. So we give atropine like drugs which try to dilate the vessel, dilate the bronchioles, so that they can relax the respiratory passage. So also the bronchoconstriction may takes place not only by parasympathetic but also like because of some gases, some dust, cigarette smoke, due to some bronchial infection, microemboli. So all this may also lead to constriction. So you can see the local secretory factors which cause bronchial constriction, like you have histamine. Normally histamine is a vasodilator, but here histamine is a bronchoconstrictor. And the reactive substances of anaphylaxis, like allergic reactions released in lung tissue, these are mainly this histamine and anaphylactic reactions. All these are released from the mast cells. And pollen obstruction, allergic asthma, smoke, sulfur dioxide, smog initiate local non-nervous reactions. So even local factors may also lead to bronchial constrictions of the airways. Normally, the mucus is secreted by the mucus goblet cells and also submucosal cells in our bronchioles or in our air passage. So why they are present mainly is to trap the small particles. So after trapping it, they need cilia. They are mainly lined by pseudostratified columnar ciliar epithelium. Histology I already explained. So because of this cilia, actually there are like 200 cilia. They beat 10 to 20 times. That is called as power stroke. Because of this power stroke, the mucus is cleared, and the mucus is now can easily enter towards the pharynx, especially to the nasopharynx. So it can be expelled out, or else it can be swallowed by the mouth, so that this